these things, we ignored it. They had to have those symptoms right at that time. We waited 5 minutes, redosed, and then went to the OR. We figured if it was safe for an acute MI, it would be safe prior to surgery. Then post-op, we repeated at Q12 until they were able to take PO medications. And then we had oral medications using hold orders. Now, a lot of people say, gee, should we titrate to rate? Should we make it really complicated? We didn't do that. We had hold orders for safety. Okay, next. What kind of surgery? General anesthetics, standard post-op pain relief. Next. Who were these people? They were VA patient A and B. You've seen them, right? 40% had coronary disease, 10% had CHF, bunch of risk. Next. Were they on a lot of drugs? Yep, all the standard stuff that you're used to. Some people have asked, well, gee, you didn't quite randomize on beta blockers. If you throw all of these people out, there's no difference in the study. Next. What happened to them hemodynamically? Anesthesiologists get very scared when you do something. Should you have some terrible event in the OR? And the answer is no terrible events in the OR, no changes in blood pressure. The heart rates were a little bit lower, but they weren't a lot lower. Next. Did we give some fancy drug to keep these people from collapsing? These are all the drugs that we give in the OR to keep people from collapsing hemodynamically. No, there was no difference in what we did in the OR. Next. What did you see? Well, you saw that the heart rates were a little lower in the atenolol-treated group than placebo, 75 versus 87. Okay? Now, a lot of people will tell you to drive the heart rate super low. These people did not have super low heart rates. The thing that they had was that their maximum heart rates were a little lower. And this may be a very important number. The atenolol-treated group had a maximum heart rate of 113, and the placebos had a maximum of 130. And I'll show you some data later on which will show how important this is. Next. What happened? Well, we cut the risk of perioperative ischemia about in half, 24 versus 39. And if this is all we showed, I wouldn't get to come to Minneapolis to talk to you. Next. We showed that the heart rates were a little lower. Next. But the next thing we said was, gee, 21 people died in the placebo-treated group and 9 died in the atenolol-treated group. And when I saw this, I said, gee, there's something really strange going on. We better be very careful about this. So we waited till we got to 5 years to publish this data. We didn't want to publish something that was wrong. And so we waited out to 5 years. Can you go back one slide? Okay. But 19 days to first death in placebo, 237 days to first death in the atenolol-treated group. I took the death certificates and I piled them up on my desk. And there's a little pile and a big pile. It's really obvious. Next slide. Multivariate analysis. Diabetes is bad for you. Atenolol reduces the risk. Next slide. And here's the survival curve. Okay? The atenolol-treated group had a lower mortality rate. Now people say, gee, this sort of is an early phase. What happened out here? They stay parallel out here. We didn't randomize or do some funny thing. We prevented death in the early perioperative period. Next slide. Ischemia is bad for you. Here's the risk for people who have no ischemia. Here's the risk for people with ischemia. Next. And the take-home point is a single 1-minute episode of myocardial ischemia reduces the risk of perioperative cardiac morbidity and death. Decreasing the incidence of myocardial ischemia reduces the chance of death. And atenolol reduces the chance of myocardial ischemia and death associated with major surgery. Next slide. Now, when you tell people this, they think this is kind of strange. Here, I gave a drug for a week, and I had this long-term effect. How could that be? That's kind of weird, right? Well, let's do a thought experiment. Let's take 200 people with hideous coronary disease, the worst coronary disease we could ever imagine, right? And 100 of them I'm going to send to Taliban boot camp, okay? A week of forced exercise. I'm going to get a shock stick. I'm going to shock them every time they don't run. I'm going to have them run all night long. No food. Just, they don't get to drink anything. Run, 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 run. The other 100, I'm going to put in a comfy chair therapy in a hotel with TV and catered meals, right? Now what's going to happen? The guys in the Taliban boot camp group are going to crack a plaque. They're going to develop unstable angina. They're going to have ischemia. If they don't die during this week, something bad is going to happen to them in the next couple of months. Okay? These guys, nothing is going to happen. Right? Now, if I did this, you would never say that the comfy chair therapy was protective for 2 years. We all understand that this initiated something